unfortunately, the way this is presented, it's presented as poisonings. Okay, so it's not going to look like what we usually see it as. It'll look a little different, but just understand it's the same principles. And we're not really dealing so much with the GI stuff. We are going to talk somewhat about the dermatitis inducers, as you see, is the second topic. And that's probably the most common of what you see. The rest of these are really not something that you normally would see out there, unless you're dealing with somebody that's eating mushrooms and stuff. I don't know how good this battery is in here. It doesn't seem to work. So what do you see usually on a patient? And this is true, not only is this for oral ingestion, but this is true for also cutaneous kinds of exposures. So when you look at this, even though it sounds like, oh, well, why would they have nausea, vomiting, cramp? Because cutaneously, as you know, we absorb things through the skin. Skin's a pretty good barrier for the most part, but with these chemicals and these plants, with the chemicals they contain, they can bypass our barrier system in the skin because they have proteins that will carry that irritant into our tissue and into our bloodstream. So of course you might see some redness. Think of rheus dermatitis, which is things like poison ivy, poison oak, poison sumac. So you might see that at the site. Always check the airway, which is what this is saying. You look for excessive salivation, sweating. You may get nausea and vomiting. If it progresses to the point of coma, you're in a bad situation. What you have to think of with these exposures, and when we're looking at anaphylaxis, which is what this is talking about, is that that airway needs to be protected. You don't want to have to try to tube somebody whose already lips are out to here and is having trouble breathing. You're not going to be able to tube them. You want to make sure that you understand the progression of what's going on, so that if they have to have their airway controlled, you can do it sooner rather than later, because you won't be able to get it later. Okay, so that's important to understand, that just because they have a cutaneous reaction does not mean they can't have anaphylaxis. And this is more common that we'll see with wasps and bees and ants and whatnot. But same thing as always, the treatment, supportive. Ingested material, not so much for cutaneous issues. I want to bypass this. This is something we'll talk about at a later time. Where's my stings? I think I must have passed it. Crap. Hang on a minute, I may have passed it. Yep. Okay. Now, let's talk about the common things we see. Of course, being in Florida, we can see this any time of the year. But during the hotter months, of course, we see more of it because these insects and organisms are more irritated because of the heat. They get more angry, for want of a better term. So we see things like bee stings, and there's different types of bees and different types of venoms. You can get local reactions, which most of us have had. We've seen it. I had one here from something that bit me. I don't know what that was. And that's just usually a little redness at the site, not much else. Okay. Sometimes those types of bites, though, or stings can progress to cellulitis and infection. And it's not necessarily because the organism that bit you carries it, but it's because of what was on your skin when you were bitten and injected into the tissue. And that's how you get the infection from it. You can get swelling at the scene. You can get anaphylaxis. That's why it's important to understand what that syndrome is going to look like. And that may present as headache, weakness, nausea, vomiting, and may progress to respiratory distress. Now, if left untreated, any of these organisms can result in death. They can kill you. And that's really a result of whether or not you are sensitive to their venom. If you've never been stung by a bee, you're not going to have anaphylaxis the first time you get stung. And that's a general rule that's true. You have to build up an exposure to it and a reaction to that. And it takes time to do that. It takes a couple exposures for your body to react in an anaphylactic way. Now, the drug most commonly that you see that causes a problem are the ACE inhibitors. Those are the ones that can kill a patient. Those are the people that present with the swollen lips, the difficulty swallowing, the angioedema, and most of the time, very rarely is that patient never had that ACE inhibitor. they've had it sometimes for years, and for some reason they develop this sensitivity to it and then develop this angioedema. But the same way they look clinically is what somebody would look like who's progressing to anaphylaxis. Okay, they're going to get swollen. And when you see that, especially around the face and mouth, you got to make sure that airway's patent. ABCs, obviously, you remove the stinger. How do you remove it? You brush it backwards. Don't go squeezing it, trying to pull it out. Just brush across it. You don't want to inject more of the venom into the patient. You want to know patient history if you can get it from them, if they're able to talk to you. If they can't, or they're getting kind of hoarse, bad sign. You better be prepared to tube those people. They may need pain medicine. Let me talk about epi for a minute, because this is controversial. 2 years ago at the Gathering of Eagles conference in Dallas, there was this debate about epi-IM. And the debate was, one group of doctors in the studies that had been done within the last few years recommended 0.5 milligrams IM be given to everybody. There was another group that said, no, I don't agree with that. I think 0.3 is appropriate to be given IM. They don't use the sub-Q anymore. They found that the absorption was too erratic, sub-Q. So now it's been IM for a while. So this debate went back and forth, and what I came away from that debate with was, okay, if you have a patient who has other comorbidities, who's a cardiac patient, who's got coronary disease, who's had stents, who's a hypertensive, maybe 0.5 isn't the best choice. Maybe in that patient would be 0.3. Okay, but if you have a healthy patient, 40 years old, 30 years old, 60 years old, who has no comorbidities, no other chronic medical problems, 0.5 is fine. It shouldn't hurt them. You can repeat it if you have to. Okay, so that's what I would usually recommend for us as what we do internally for our protocol. Sub-Q has fallen out of vogue. Who knows? Maybe in 3 years it'll be back again. But for the most part, just remember the dosing difference. Okay, and that's true with a lot of meds that we use, but particularly with epi. Okay. Now, let me point this out to you, because a lot of times people don't realize this. You see under wildlife, we talked about honeybees, and most of the time their venom's nothing that's major, maybe a little local reaction. Now we're talking about wasps, yellow jackets, and fire ants. Why are wasps and fire ants the same? What? No. Why are they the same venom? You guys remember when you classified organisms in biology, genus, species, all that stuff? Remember that? Fire ants and wasps are from the same genus in the classification system. So that means they have the same venom. Of course, a fire ant's this big, but if you're allergic to a wasp, when you get stung by fire ants, you're going to have an allergic reaction, and vice versa. And I know this firsthand, because when I moved to Florida, I wasn't allergic to stings. But within a couple of years, after getting bitten enough times by fire ants, I became allergic to fire ant stings to the point of near anaphylaxis. So I get sweaty, I swell up, I get short of breath, I get tight in the chest. And I carry epi, I have epi at home. I don't carry it with me. I just don't go out in the yard. So basic stuff, your ABCs, ice pack. Need to know about allergies. Analgesics, why? Well, a lot of these people are going to have pain. But I think the more important thing is make sure you establish a line if this patient looks like they're at that point that they can progress to anaphylaxis. Because you'll never get a line in them if they're in anaphylaxis already. You want to be prepared to do what you need to do. Now, what do I do in the ER for patients that have an allergic reaction history, even if they're not have progressed to anaphylaxis? There's only one difference I do. So the patient comes in, they're having an allergic reaction to something, whether it was a cutaneous thing and they're getting some systemic symptoms, or whether it was a sting or a bite. They get IVs, they get IV Pepsid. Why do I use Pepsid? What is Pepsid, Zantac, Tagamet? What are all those drugs called? Okay, they're H2 blockers. They're histamine blockers. They stop histamine release, and they work fairly rapidly. So they all get that IV. They get Benadryl because that's what we have. Any antihistamine would work, but Benadryl, Benadryl, Vistaril, Atarax, they're all general histamine blockers, okay? Mostly H1, a little bit of H2. So we have to block both of them, so they get Benadryl, they get Pepcid. What else do they get? They get a steroid, okay? They get Solumedrol, IV. Epi I use only if I think the patient really is almost on that border, then they get Epi-IM as well. But those are the three basic drugs that they get for every sting, and they've all had very good results. Within an hour, most of them are completely resolved. Now, we don't carry Zantac on the rigs, okay? May not be a bad idea to carry Pepcid or Zantac. It's an H2 blocker, especially if you're more than 30 minutes from the hospital. Because now you've gotten that in their system and it works fairly rapidly. It's not like the proton pump inhibitors. And Pepcid was used for, and maybe to some extent you see it advertised, you know, for GI issues to prevent ulcers and all that kind of stuff for people with that kind of history. Indigestion, GERD. The newer ones are called proton pump inhibitors. They don't have any anti-allergy effect. And they also take up to 20 hours to do anything. So to give somebody something of that type of drug, and they do make one that comes in IV form called Protonix, would be useless. So the drugs they would need would be Pepcid, Zantac, Tagamet. Those are the main ones on the market today. And they're old drugs. They've been around for years. So that's what I use as a basic approach to these patients. Analgesics, if they have a lot of pain, yeah, some of these stings can be very painful if you've ever had them, especially wasps. Black widow spider bites can be intensely painful. The arachnids, and here's black widow up here. So what's the difference between these? Well, anaphylaxis is anaphylaxis generally. So if we go back and look at what a patient's doing with these types of stings, wasps, yellow jackets, honeybees, fire ants, and then we come and we look at the arachnids or the spider type of organisms, you notice that what do you have in here? You have muscle spasms, you have fever, you have hypertension, you can get belly pain. A little different than the other ones, okay? And that's because their venom's different. I mean, the basic stuff's pain at the bite site, swelling at the bite site, piloerection means your hairs are standing up, sweating, tachycardia, you can see that with the other things. But normally you're not going to see hypertension, fever, muscle spasms, and abdominal pain. A good example of a black widow bite, and I've seen this a dozen times or so, a patient comes in with belly pain, and their belly's rigid. And I always used to wonder, how many of these people went to the OR thinking that they had peritonitis or acute appendicitis? Because in the old days, there was no CT scan to look at the appendix. It was all a clinical diagnosis. So how many of these patients actually went to the OR and they had a normal appendix removed? And in retrospect, here they had a black widow spider bite that wasn't noted by the patient because they didn't think of it. More commonly, I saw this up north. I've only seen a few in Florida. But frequently with the black widows, they will give you belly pain. That's a common finding with them. Ticks. I've seen one case of Lyme disease in Florida in the last 20 years that I've been here. One case, and the only reason this patient had Lyme is because she came from the north, or she had gone up north for vacation, came back, and she presented with a bullseye rash. And nobody knew what it was. Well, in Florida, they wouldn't necessarily know that because they don't ever see it down here. And unless you know the literature and have seen a picture of it, it can easily be missed. But I saw her in the ER at the Cape. She was a young girl, like 16 or 17. Did the Lyme titer on her, put her on antibiotics, and of course her titer doesn't come back right away. It came back a few days later, and one of the ER docs called me and said, "Hey, who the hell did you do a Lyme's titer on?" Because it came back positive, and they had to call the person to tell them. I said, "Oh, a young girl that came in." He said, "How the hell did you know she had Lyme's disease?" I said, "She gave me a history of exposure to a tick." Well, he said, "Why did you even ask that?" She came in with complaints of muscle aches and cramps and pains like she had a virus. And he wasn't being critical. He was asking because he said, "I would have never thought of that." And he said, I wouldn't have even. I said, "Well," I said, "you just, in the course of talking to the patient and looking at him, you come up with, a line of questioning." He said, "It was just serendipitous. It just happened to work out that way." So belly pain is common. I'm not saying every patient you get a call on for belly pain, you should think of black widow, but Think of it this way. If you get called for somebody with belly pain who's outside working at Lowe's or Home Depot in the wood piles back there, or out in the woods working, and you get called for somebody with abdominal pain who's on his front end loader, then that's something you should consider. You know, you might want to ask them, you had any bites today? Do you feel anything biting you? You have any marks on you? Maybe something you want to ask. These are just some examples. I don't know, can you see that hourglass mark on that black widow? I have them on my lanai. I had to get rid of them. I don't have any little kids, but. So you can sort of see it. I don't know if the patients are going to think, unless they actually know the black widows are there, they see the spiders, they're not going to think of that. And most people may not know what they look like in terms of the hourglass mark on their belly. But their venom can be pretty toxic. So these patients, again, ABCs, you may need a line. They frequently have pain out of proportion to what your findings are. Brown recluse. You know, I have not ever read, and if somebody has seen this in the literature for Florida, then please point it out to me. But I've never read, when I look at the entomology of where these spiders live, that they live in Florida. Never seen that. People come in with these terrible looking lesions from bites of some sort, and that is not a brown recluse. They all say, oh, it's a brown recluse. I said, no, it's not. I've seen brown recluse bites. This is not brown recluse. Brown recluse spiders inject a venom that is necrotic. That tissue just sloughs off. You have a hole. You have a hole in that tissue where you could see the muscle underneath it. That is a brown recluse. These little bites that look infected, they are infected, and it comes from, is that me? Just fall off? No. It comes from the junk on our skin that gets injected into the deep tissue. So it's our own crap on our skin that is what's being injected into us, more so than the venom. Yeah, the venom causes a local reaction, but that bacteria mostly comes from what is being injected by what's on our skin. So you get somebody that comes in with a horrible looking infection, more than likely it's MRSA, more than likely it was already on their skin. And if you think about how we practice visitor control in a hospital and hand washing and everything else, you know as well as I do, filthy people come in there growing MRSA on their skin who have no reaction to it, touching everything in sight. They touch the elevator buttons, they touch the elevator button, they touch the railings, they touch the doors, they go into patients' rooms who have infections and they don't have gowns or gloves or anything on. They touch these people. So most of that comes from our own ineffective control of visitors and infections. So what are you going to see? Well, this is true of almost all of these. You're going to get some itchiness, of course. Erythema and edema, that is not only with a brown recluse. Papule formation, you can still get that with the other lesions, other stings. However, that necrotic lesion is unlikely to occur with anything else. It's usually a brown recluse. Bullseye rash, more so with the tick for Lyme's disease. If this goes on long enough, you can get fevers, chills, malaise, and weakness. Here's something. What's tick paralysis? Now, we have ticks in Florida. And I've seen this happen. I've had maybe 2 patients in 30-some years with tick paralysis. Tick bites you, it injects its venom, you can't move your leg. Take the tick off, within a few minutes, you're moving your leg fine. So you see a young person who's a hunter or a fisherman, and they tell you they can't move their right leg, all of a sudden they just, what do you want to think about? You want to think about, geez, could this patient have a tick that, now, once the tick is gone, the paralysis goes away. So they're not going to get bitten and the tick disappear, and they're going to still have a paralysis. That's what I'm saying to you. It has to be there for them to have it, because what it's injecting in them and feeding on them, its venom is keeping that nerve from functioning. And what it does, it blocks the impulse in the nerve. So that is around. I've only seen it a couple of times. Fortunately, it's not common. Nausea and vomiting. Do you notice with almost all of these, nausea and vomiting is one of the symptoms. Because of what? What happens in the GI tract with histamine release, with anaphylaxis? You get swelling of the tissue. It gets engorged, gets swollen. It's going to make you nauseated. So you're going to start throwing up. Plus, you get changes in the hippocampus that may make you vomit as well. Notice you can get rash sometimes. The worst things, of course, seizures, hypertension, and DIC. Fortunately, I've not seen that with any stings or bites. Treatment, if you notice all of these, the treatment's pretty much the same. Now, these are just, this is really hard to see, so you can't see this, but this second picture here is what it looks like. That is black necrotic tissue that will slough off. It'll just fall off, and you'll be left with a big hole. This is just an area of redness, erythema. You'll see that the papules are all erect in here, so it feels real bumpy, like sandpaper. And the top one is some petechiae, and that can come from any of these bites. Petechiae, usually an insect that has an anticoagulant, and its venom keeps the blood from clotting, so you'll get what looks like a big bruise. But they're more petechial in their look. You can get the bottom one with almost any of these organisms. Scorpions. I don't know what kind we have in Florida. Has anybody seen scorpions running around? Where'd you see them?
I used to live in a house that instead of cockroaches I had.
You had scorpions?
Yeah, they were black.
Were they? Okay.
They look exactly like that.
One on the left? Yeah, it says the bark scorpion is the one that's a problem. I've not seen any, so the bark scorpion, notice that it does have more systemic symptoms than most scorpions. Besides the local pain, you can see pulmonary edema, respiratory distress, hyperactivity, meaning a hyperexcitable state of the neurons. So the patient can be agitated, can have tremors and seizures. It should be shortness of breath. It comes from two things. Part of it's pulmonary edema, which you know if you get fluid influx, of what we call a capillary leak syndrome, meaning the fluid oozes out of the capillaries into the interstitial space. That's part of it. The other part is some of it can be diaphragmatic from some dysfunction of the diaphragm from paralysis or partial paralysis from the venom. So when it says that, and they're talking about this kind of organism, that's what they mean. ABCs, IV, O2. There's nothing you can really do on the outside for them. It's going to be mostly supportive. And I don't know if we carried any kind of anti-venom in this area for this particular kind of scorpion. We did have some for black widow bites. We do have some for snake bites, and we'll talk about that in a minute. But in terms of this particular scorpion, I don't think we have anything. I believe there is something out there, though. Again, I mentioned tick paralysis. Depending upon where the tick is attached, it can be fatal. It can stop your breathing by paralyzing your diaphragm. Okay, so let's talk about things that we do see around here, and that's the pit vipers. Now, there's a misconception that every snake bite from a pit viper is potentially lethal. And if you want to use the term potentially, yeah, we can say potentially. However, not every snake bite is one of envenomation. Many years ago, there was, and I don't think it's in there anymore, in the Tintinelli's emergency medicine textbook, Principles of Emergency Medicine, I think it's called, there was 4 stages of envenomation for snake bites. And I have not seen this table in probably 20 years. I don't even know if it's still in the book. I haven't seen it. And it all had to do with whether or not there was envenomation, and it dealt with how big of an area was involved and the progression. Okay? So progress from a bite with some fang marks, but no redness and no erythema, all the way down to erythema. You see this, you might see the marks if it's not too swollen, but it is going to be reddened. It may also be black and blue and cyanotic, depending upon how long it's been going on. And it's progressive, meaning that you'll see it rising up the extremity, because most of these are on the extremities. Okay, and that's how you tell if there's envenomation. Even when you get called to the scene, you look at that wound and you see what it looks like. If it's pretty reddened and swollen, and that extremity is pretty swollen, then there's been an envenomation. If there's nothing there but a couple of little tiny red marks, then more than likely it was not an envenomation. So just remember, not every snake bite is an envenomation. I'm not saying that if it doesn't look like there's an envenomation that you can ignore the patient and tell them to go home. What I'm saying to you is that you can calm them down and say, you know, it was 30 minutes ago, there's just a tiny bit of redness. The whole extremity's not red, the foot's not red, it's just these two little marks and that's it. It probably wasn't an envenomation, but we'll take you to the hospital and you can have the doc check you out. You probably need tetanus anyway, and these are gonna get infected. So I've had snake bites that I have not given any kind of antivenom to because there was no envenomation. I would watch them, 6 to 8 hours. I'd mark the area and there's no change. Antibiotics, tetanus, if they needed some pain medicine, and out they go. So you look for the fang marks, the swelling, pain. If there is envenomation, patients will develop diaphoresis, nausea, and vomiting. Those are the most common symptoms you're going to see. Okay. If it gets progressive, they can have other issues such as shock, cardiac arrest. Ecchymosis at the site of the wound, that's a negative sign. That's not good if you see that. Swelling, you will see. Again, that's not a good sign. Okay. The other things that we mentioned, nausea, vomiting, diaphoresis, shock, weakness, those are more systemic. And that means the venom's progressed far enough into their system that it's now affecting their overall body. You certainly don't want to get bitten by the snake that's bit them. And I have a story from years and years ago up in Pennsylvania. I was working in Chester, Pennsylvania. 2 million people, all the industry left the town. There were 2 million unemployed people. A lot of alcoholism and drugs. There was the community around them contained people that worked mostly in the upper levels of factory manufacturing and service, and a lot of office people and whatnot. So they were still pretty well off as opposed to the people in the city. So we get an ambulance, and understand that outside of the cities in the Northeast, almost all the ambulance services and fire services are volunteer. There's no paid service. These people are all volunteers. So one of the volunteer squads calls in and says they're bringing a patient in that hit his head and was confused, and he had been unconscious, and they didn't do anything. They didn't resuscitate him, nothing like that. And also, he has a broken leg. Okay. So they bring the guy in, and assuming that he fell and broke his leg and hit his head. That's what you assume, because they didn't give you any other information. So they bring him in, and the medic or the volunteer guys drop him off, and they said, "Doc, you wouldn't believe this." And I said, "Why?" I said, "What are you talking about?" He goes, "Well," he says, "Tom hurt his back." Tom was one of the volunteers. He said, "And Joe hurt his foot on this run." And I said, "Well, how'd that happen?" He said, "Well, they dropped the stretcher." I said, "What?" He said, "Yeah, we were coming down the stairs and they dropped the stretcher, and they dropped it, the stretcher rolled down and fell off the stairway on top of the guy who was tied to it, and that's how he broke his leg." I said, "What the hell?" I said, "Don't you guys know how to move?" He said, "Doc, you don't understand." He said, "We got a call to go in there." He said, "The guy is laying on the floor in the bedroom naked with a big gash in his head." The neighbor's there, the wife is there, and we said, what happened? And she said, he hit his head on the fan that's over the bed. And